I'm very pleased to welcome back Daniele Corlazzoli again for this second session. He spoke in the first session already. Daniele is an ECVN, and I think it always enriches our surgical session if we have perspectives from the other side. And Daniele, of course, is an established neurosurgeon, and he's going to have two upcoming topics, and he will start with updates on cervical spondylomyelopathy. Thank you so much for being here.
Thank you, Bianca. Welcome to my session. I'm lucky enough to start. We started studying this disease when I met my tutor at the university, because as we say in Italian, it's better to be lucky than rich. And he was used to feed us with papers from the best journals at the moment. And I can tell you that unfortunately not much changed in our literature about the basics on spondylomyelopathy. So I have no financial conflict of interest to disclose. I'm not a seller of implants, and I just buy implants as like anyone in the room. So let's start from the literature. Very conflicting result. CSM is usually successful with approximately 80% of dog improving after surgery, whatever you do. You know, you are surgeons, and there is not one such a sentence that can stand up. There is no treatment that are really equivalent. And every treatment is equivalent in terms of success. And some papers state also that medical treatment is just as successful as surgical treatment. So my purpose here is try to change perspective and try to see if indeed we can change our decision with behavior. So we're going to raise the doubt if indeed surgical treatment are different between each other. So let's start from numbers, because literally it's about numbers, but it's also about torturing numbers, because sometimes authors force the conclusion of a paper to a good results. It's very difficult also to compare papers indeed, because of the low number of patients, there is a bias related to the population, because maybe you are finding more severely affected dogs or different breeds or different sizes, and patient heterogeneity. And also low agreement on diagnostic criteria. So if you go back to papers, If you go back to papers on agreement among radiologists, you will see that indeed is not so good the agreement. And of course bias, because we tend to report on positive results. We tend to make results positive even if they are not that positive. Unfortunately, that's probably human side. So treating spinal cord disease, I think we are all agreed that we should maintain normal mobility, enable a steroid-free life, and prevent clinical deterioration. That's the goal for every surgeon, of course. And since it's very difficult to compare those papers based on success rate, why we don't compare paper based on complication rate? Because maybe this can give us a better understanding of the disease. And also because as a surgeon, we know how bad they afflict our mood, how much time do we need to overcome a complication. So how many complications we can need for steroids, loss of distraction, loss of decompression, loss of mobility, progression of clinical signs after surgery, violation of canal of foramen, recurrence of the operation, euthanasia. But also we need to start from somewhere. We should assume that euthanasia should not be an option for a treatable spinal condition in 2024. Okay? So it's not acceptable that a procedure evolve accepting the fact that some percentage of patients will undergo euthanasia. We have focused only on single lesion, just because multiple lesion will require a completely different talk. So, and also because the literature is focusing only or mainly on single lesion. So let's start from some definition that were recently introduced in our literature. ASP and ASD, adjacent segment pathology versus adjacent segment disease. What that means, adjacent segment pathology, is that abnormality in the adjacent disc space that is not causing clinical signs, but it is related to the surgery we did. So it's not the natural evolution of the disease. It's something that is related to surgery. And when we speak about adjacent segment disease, it's a recurrence in the adjacent disc space causing clinical signs that can be related or unrelated to the surgical technique. Such as in this case, an infection in the C71 that is related, of course, to the implant and causes clinical signs. So this is adjacent segment disease, and this is not adjacent segment pathology because it's causing clinical signs. Well, another definition I think we should remove it from our literature, because this is misleading. Because when I first started studying this disease as a student, the blame was given to, the world was divided in East and Western countries, and the surgeon performing slots and surgeon performing stabilization. And there was no agreement between those two words. And the blame was given to the stabilization in terms of recurrences. So we thought that if you do a stabilization, then you force to increase the rate of recurrences, even if the literature was very clear from the very beginning, because in 2001 there was no difference in the recurrence among surgical technique. So ventral slot had the same percentage of recurrence compared to distraction fusion. So domino is not a consequence of a fusion. And in human being as well, patient can be treated for CSM, for cervical spondylomyelopathy, with disc prosthesis or disc fusion or fusion distraction, or even discectomy. And the incidence of recurrence is just the same, and also the incidence of adjacent segment pathology. So it's something we should step away from. If we consider this patient that was operated for a long implant and then had a recurrence down the road, so according to the domino effect, we should assume that the increased load has a role. So you remove the disc, you cause an increased load in the adjacent disc space, and then this causes a progression of clinical signs. But if this assumption is true, why don't we see the same problem with all the stabilization we do in our field? Because we don't see adjacent segment disease in C1, C2 stabilization in puppies that have 15 years to live after stabilization, and we don't see neither with hemivertebral fracture or lumbosacral. So the increased load is just something that we use to justify our reluctance to perform more complex surgery. There is not one such principle that can be demonstrated. But be aware, that's my point of view. I told you surgery is mainly a matter of point of view. Okay, we know we are surgeons. Be aware of not being responsible for adjacent segment disease, because that's something different. So bulkiness of the implant can change or can cause adjacent segment pathology, and you don't have to be optimistic about what is going to happen down the road just because you're not going to see the dog after 2 years, 3 years, 4 years, because somebody else will treat it or euthanize it. Okay, we should do surgery that will not cause adjacent segment disease or pathology. It might be very easy. Very easy. Nothing is very easy, of course. But you can reduce conflict with the adjacent disc space just by changing the inclination of the screw that keeps the PMA away from the adjacent disc. So that was a solution. Or you might use a thinner implant that is not causing conflict with the adjacent disc space. Or you could place the plate far away from the adjacent disc space, because in human beings it's well known that among the predisposition factor, beside needle in the adjacent disc space for fluoroscopy or excessive periosteal dissection, even if you place the plate too close to the adjacent disc space, you are damaging the function of the adjacent disc space, you are favoring the reaction. So reactive spondylosis is a complication of surgery and is not a natural progression of the ACSM. What about subsidence? A new word that appears in our literature. Subsidence refers to the natural decrease of height of our disc while we age. So that's a natural physiological event, pathophysiological. And when we go to the surgical field, this is related to the loss of distraction that is caused by bone graft reabsorption with remodeling, or graft collapse, or graft pistoning effect into adjacent vertebrae effect. Is it relevant or not? Well, I would say that probably to become a surgeon, you need to be optimistic from the very beginning. So if you hear a surgeon at the bar discussing about vertebral surgery, well, complications are not common and the complications are not relevant. Well, indeed, the literature seems to state in different options, because distraction fixation surgery often fails because of loss of postoperative vertebral distraction. And that was written by Jeffrey McKee in 2001. And again, early implant failure with loss of distraction before fusion have been the most common cause of failure. Again, so subsidence is not a benign event. You can be lucky, but it's not a benign event. Do we know which degree of subsidence is relevant? No, we don't know. They don't know in human medicine either how much subsidence is acceptable. But for sure, if you did CSM surgery, you remember the patient who was walking so nicely for weeks down the road, and then all of a sudden, in one afternoon, became painful and started walking again with hypermetria, or eventually progressed to tetraplegia or infection or other complications. So that's a subsidence. And it's a responsibility of a surgical technique. It's not a natural evolution of the disease. We know as a surgeon we need to face our own complication and we need to overcome obstacles. Another definition that we need to get confident with is the difference between major and minor. That is not about major chord and minor chords. It's about major complication and minor complication. The problem that I'm a little bit disappointed about this definition is the fact that the same complication, so the same plate rupture, can be considered a minor complication if the clinical signs are mild, or a major complication if it is an awful consequence. But I think that nobody would buy a bike that is meant to break his frame in the first 4 weeks. And implant failure is a complication and implies a structural issue and should be addressed and solved. Nobody in this room would buy a TPLO plate that is meant to break in 4 weeks. Why would we accept a spinal implant that is meant to do the same? And because the complication is a toss of dice, so it depends how lucky you are, or it's because of the temperament of the dog. So the same plate rupture, the same screw rupture can be catastrophic in a very active dog, or can be benign in a calm patient, or maybe comorbidities can have a role, because if you're operating on a hypothyroid dog or on a dog that had been on steroid for 6 months, the chances of infection with a plate rupture is of course much higher. And as the old man says, usually dogs in papers tend to have far less severe complications than in real world life. You all know that. So let's jump into treatment. Let's start from medical treatment. First question, how long should we treat with steroids or non-steroidal this patient? Well, this paper answered this question and says clearly, dogs not improving in the first 4 weeks are bound to get worse in the next 12 months. And this is a very good communication tool when you speak with owners, because you say, well, your dog has already been for 2 months on steroids and now he's waxing and waning with his weakness. What do you want to do? The clinical signs are mild, but the history is witnessing the fact that it's going to get worse in the next year. So let's do surgery when it's time for doing surgery, not when it's too late. But there is other paper, 2008, JAMA, mean duration of dexamethasone up to 2 months, mean duration of prednisone up to 3 years. Can you justify a medical treatment for a spinal treatable condition for 3 years for a young patient that is a surgical candidate? And if we compare those two papers, only 50% of the patient improved, but according to the Decker, none was free of clinical signs, so this is not a true improvement. You are at best halting progression of the disease, but the incidence of euthanasia is catastrophic, I would say. 35 to 50% chance of euthanasia for a treatable condition in a young, active dog. That's not acceptable. So it's good to offer a medical treatment to patients because it might improve, because it's ethical, because it's also good from a defensive point of view, because of course you do surgery in a dog, you have not advised a medical treatment, you get a complication, and then the owner can be mad at you. But of course you need to select the right technique. Ventral slot, very good technique when you think in terms of extrusion. We all perform this extrusion slot very well. And we know it should be limited to static compression in CSM. And because the lesions are defined as a static or dynamic based on linear traction studies, we are all very confident with that. But we oftentimes find the cases where the spondyloarthrosis prevent any distraction of the spine. So what does it mean that we should treat this dog with ventral slot? If you did it, you know how bad could be the result, and the nightmare that is going to be drilling through 4 centimeter vertebra. And if you remove the spondyloarthrosis and if you remove the disc, everything becomes distractible again. So I totally disagree with the distinction between static and dynamic lesion if it is a surgical indication. And this Labrador, for instance, it was almost complete fusion. So when do we want to go for a slot with this patient on C7-1? Or you want to distract after removal the spondyloarthrosis? And moreover, how important is traction in our publication nowadays? Those are the last 5 papers accepted for publication in CSM in dogs, that no one has a single dog investigated with traction study. But they were treated, accepted, publicated. We still do believe in traction. Yes, we do believe, of course, because this is the postulate for the compression, but we don't need to demonstrate that every soft tissue can be distracted or foramina benefit from distraction, and every disc space collapses after a cervical discectomy. This is a postulate. We don't need to demonstrate it in every single case we are facing. Let's talk about outcome. Again, the paper of comparing medical and surgical treatment, most of those dogs were treated with ventral slot. And if we go to results, well, mean desmetazone post-surgery up to 1 year, mean pred up to 6 months, euthanasia again 43%. It's not acceptable. I mean, you can hear surgeons telling that they are successful with slots. You can hear surgeons that are successful with every technique, of course. But if in the literature are 43% incidence of euthanasia for a treatable spinal condition, that means that this is not the technique we should use. Disc prosthesis developed by Dr. Adamo. Mainstay is keeping distraction, keeping decompression, maintaining mobility, avoiding overloading the adjacent disc space. That's the goal. Most of the information about the technique can be found on websites, on presentation from the author, and according to the author, 100% mild subsident, that is loss of distraction, and 77% of the patient lose their mobility at 6 months. So if maintaining mobility was the goal, well, this is lost in most of the 3/4 of the patient. This is an interesting paper from an Italian group. They compare the disc prosthesis to distraction fusion. But in the 12 patients they did surgery, they had to reoperate the dog in the first month in 25% of dog. 1 dog out of 4 went back to surgery for distraction fusion. Why? Because this is a compression, this is a nicely placed disc prosthesis, but this is what happened at 3 months with recurrence of clinical signs. So 1 recurrence out of 4, I think, is a very high incidence of recurrence. Plug, just because of historically, it's strange how techniques at the first paper are extraordinarily successful in our field and then either disappear. So many techniques we studied just disappear, just 1 paper, then nothing else. But the conclusion is that this is a very good technique we should improve. And sometimes some author can publish results down the road that demonstrated that indeed is not that successful. So here we see that the plug is a piece of PMA that is inserted into the disc to maintain distraction, but the main difficulty is to keep the plug in place, even with those elegantly placed screws. The issue is that the final issue is that, of course, the PMA found its way out. And indeed, we have a subsidence in 100% of cases, fusion 0. This is something that in neurology field they do not understand. An arthrodesis with 0% fusion is a failure. I mean, if you are a surgeon, that you don't have to demonstrate that. It's an assumption. And the 15% have an acute worsening in the first weeks. Again, 11% euthanasia. So this is not a technique you should recommend in your patient. Silox. Here we have a nice veterinary implant, titanium, so MRI compatible, and several papers. I'm going to mention only this one. We got 37 patients operated, 25 available at 3 months. Many dog improved, but 88% implant failure mobilization, 60% at subsidence, and 20% require second surgery because subsidence is not a benign event. Okay. I know they're working on bigger implants, but again, I think from my perspective, it's a very short implant, so it has very difficulty in counteracting the forces that are applied on the cervical spine. And fusion is absent in most of those patients or incomplete. What's happening in real life? This is the dog that was operated elsewhere in the 10th of August. Probably the screws are very short compared to the one in the paper. A week later, had a subsidence with recurrence of clinical signs. They put PMA and replaced the screws with longer screws. But again, when we saw the dog 2 weeks after, he was tetraplegic with implant mobilization. That's real life. So that's why we should work against subsidence. 1988, I call it the Big Bang. I was a student at this time, and just a few months apart were published 2 papers that really represented, in my opinion, the beginning of our understanding of the disease. So bicortical, monocortical with PMA for treatment of this disease. Of course, the beginning also of endless discussion, whether you should use a bicortical or monocortical screw. We had to wait almost 30 years to demonstrate that that's a nice screw. That could be nice depending on the CT you're using. That's certainly not a good event, and the patient is not happy with that because it did not take just a few days recovering it. And we had to wait probably 30 years to demonstrate that indeed the bicortical vertical implant in cervical area carries in the dog an high risk of violation. But sometimes they come back. I know that nowadays a lot of surgeons are working again in that in Europe. We'll see what the result will be. If we stick to PMA, subsidence 10%, infection 2%, probably in real life a little bit more. And what is most important, early failure, implant failure, in the first month we worsen our clinical sign. That's what we saw these days. Need to go back in surgery, replace the implant. Is there still a role for PMA? I think it is for longer stabilization, when indeed a multiple stabilization, you don't have a plate for that, or for very small patients that don't have a plate neither. So we still use PMA in those patients. When we are close to nowadays, 2006, a new revolution. It's a world revolution, CSM, locking plates. The first paper coming out from Zurich University. The beginning of a journey, still quite an high incidence of complication, but we started from somewhere. 2008, the first cervical human plate, but a very short plate, and indeed, you're not surprised by the number of implant complications, even if they did no reoperation. All the patients were successful according to the author, even if some of the patients had a recurrence of clinical signs. So how do you consider this patient a success or a failure? Just because you have not operated on it, but he had a recurrence of clinical signs. So 2011, one paper I love on this disease. I love it because for the first time it's 0 implant failure, 0 infection, 0 reoperation, 0 euthanasia. So, okay, we are close to the result. And for the first time we measure subsidence as veterinarians. So, quite a high incidence of subsidence, but with no clinical signs, so probably because it was a mild subsidence. And the median subsidence was below 2 millimeters, so a very mild subsidence. Though 69% reactive spondylosis deformans, because as we discussed earlier, the bulkiness of the implant is creating conflict with the adjacent disc space, but with no consequence in this population of dogs, of 13 dogs. I think the problem with those plates that were developed for a long bone fracture is that the distance between holes is too big. So if a plate is too long, then the next one is too short, if you want to plate 2 screws in a single vertebrae. So you can have a single patient that fits perfectly this plate, but then the next one is just a little bit larger or smaller, and will help you having trouble. SOP and screw for distraction, again a very bulky implant. Very difficult paper to work because of statistics is very complicated, but half of the patient had 100% or more subsidence, meaning that distraction was not different compared to pre-operatively. So like if you didn't do any distraction at all. Again, adjacent cell pathology frequent because of the bulkiness of the implant, but because of course, again, of the whole distance, so one plate is too long, the other is too short. But no patient required revision surgery, so we are starting to improving as a veterinarian in treating those patients. Similar technique to the Stefan technique, but with some differences. A lot of violation of this space, 8 out of 9 a violation of this space, either the adjacent disc or the operated disc space. 1 screw violated spinal canal in 1 patient. 2 out of 9 broken plates, 9 out of 84 broken screw, implant loosening, but only 1 patient required revision surgery. Why two similar techniques can have a different incidence of complication? Well, several reasons. Probably because in the patient on the right side, the 7-hole plates were used, a longer plate that helped the surgeon to invade the adjacent disc space, like in this case, or probably because a different population with larger spondyloarthrosis that forced the surgeon to bend the plate more, and if you bend the plate more, then the screw direction changes, so you are you are helped or guided toward the adjacent disc space. In terms of, again, same problem with the whole distance. Subsidence, well, pretty much the same design, a minimal subsidence, even if you should measure subsidence on CT, not on radiographs, because it's very difficult to make identical radiographs down the road. And if you are measuring differences of 1 millimeter, of course, you are very inaccurate if you are doing it on radiographs, but that's what we have. We know from the human side that when a ventral or anterior, like they say, fixation is prone to failure, then if you add a dorsal stabilization, then you can decrease the incidence of complication. And that implies understanding the concept of the central rotation of the vertebra that is approximately close to the vertebral floor, to the spinal canal floor. So we thought that maybe to counteract these forces acting around the center of rotation, maybe adding something dorsal could help us in decreasing the incidence of complication. And then we came to a conclusion that adding 2 screws in the dorsal facet could help us, and we published our first result in we presented our first result in Seattle in 2013, and again in Bologna at the meeting. So this is not a locking plate. So it's the only non-locking plate that veterinarians are using, cervical plate. The screw can toggle into the holes. And the principle behind the non-locking plates is that as a corollary of wall flow, bone heals optimally under compressive forces because the graft is under compression. And dynamic or semi-constrained plate allows for axial load and sharing with the graft, avoiding stress shield. That's the principle behind it. We used several different cages, cuttable cylindrical, cuttable bars, and recently the company is manufacturing for us just 3, 4, 5, 6, 7, 8, 9 millimeter base cages. And the plate is not a locking plate, so you need to be countered and match perfectly the bone, otherwise it's not stable. The plate accepts a maximal bending. Beyond the maximal bending of the plate, you need to sculpture the bone to make the plate fitting with the bone. So this is a major difference with the locking plate. Every step is checked with fluoroscopy to guarantee maximal bone purchase of the screw and to place the cage as close to the vertebral floor as possible to neutralize the center of rotation. And for the dorsal screw, we decided to go for a lateral approach that we do with the help of fluoroscopy and with blunt dissection, muscle fibers, and with a couple of recheck with fluoroscopy, staying outside of the room, of course, because of protection. You get to the lateral facet, where it's very easy to understand what is the best trajectory for the screw and avoid the dorsal axis that we all know. So then after the lateral axis is done, we insert from the dorsal plane a bone biopsy large enough to accept a 2 millimeter cushion wire. So we insert it down to the facet. We remove the stilette. We insert a 2 millimeter cushion wire that we use as a drill guide. We drill through the facet, then we remove the bone biopsy, insert the screwdriver, and the screw is inserted through the axis. At the beginning, we were thinking of using cannulated screws, but this is more expensive and they are thinner screws. So a 2.7 cannulated screw would be very weak. So we use 2.7 screws in this way. And this is how it looks like, and it allows you to also do burring of the cartilage and cancellous bone transplantation. We always perform a postoperative CT to check for implant positioning, and we did in this study recheck at 3 months and 6 months, and all patients were fused by 6 months in the dorsal facet and the joints in the disc space. Good decompression. We did 43 patients from 2011 to 2023, no violation of vertebral canal, no foramen violated, one screw mobilization, one immobilization of one implant, and one patient out of 43 had adjacent segment pathology. The big advantage of these cervical plates for human is that they differ 3 millimeters one from each other. So if you think the plate is too long for one patient, you have a plate that is shorter, 3 millimeters shorter, allowing you to place 3 screws in each vertebra. 3 months post-op, 1 year post-op, 7 months, 3 years, day 0, 6 months, 1 year post-op, 2 years post-op. 2 years post-op. This is the dog who developed adjacent segment pathology. The plate is quite long because in the beginning we stemming from our orthopedic education, we tended to use longer plates, but I can tell you that the shorter plate it is, the better it is if you can place 2 or 3 screws in each vertebra. And this dog had also mobilization of one facet screw. This is the single dog who developed adjacent segment pathology with a short plate. And you can see that the incident, it's clearly evident that the reactive spondylosis is much less a consequence of this technique. This is the single patient who broke the plate, who broke the screw. He was left unattended 5 days after surgery, running behind his cat in the garden. Probably the screws in the dorsal facet prevented the dog from having a catastrophic consequence, and the dog was just going from a normal gait to mild hypometria in the front limbs. And of course, we measured on CT, not comparing to pre-op, but comparing to post-op. Median 0.46 millimeter, not something you can really measure on radiographs, of course. No euthanasia, of course. If we have a lot of discussion in Italy about this technique because we have been discussing for 15 years. There are several different ways of doing it in Italy, like always, of course. And Dr. Falzone published this. This was the comparison we mentioned because of the disc prosthesis. And he used the 2-pax locking and the dorsal axis for the screw positioning in 13 patients. He had subsidence associated with breaking of a screw in 3 patients with disc spondylitis in 1, and 2 further patients had disc spondylitis. So quite a high incidence of disc spondylitis. Yes, I'm almost done. And why this happened? I think because subsidence bring the plate more close to the adjacent disc space, so the conflict increases. And because it's a matter of luck, because also our patient had the same complication but no infection. So why two similar techniques can have a different incidence of complication? Well, probably because of the plate, because again the distance between holes is 9 millimeter, and because probably dorsal or lateral approach make a difference, because I think that, you can see that this is the dorsal facet, and in most dogs the channel for insertion is 5 millimeters or less, because you see the burr is a 5 millimeter burr. If you want to place a screw across the 2 facets, you have only a 5 millimeters channel. It's very difficult to appreciate it from dorsal, in my opinion. And indeed, if you compare dorsal and lateral approach, you can see that the screw on the dorsal are at the periphery of the caudal facet, and the one in the lateral is dorsal, is central. And this was presented at ECVN last year. And again, from dorsal, you can hit the center of the facet, or it could be at the periphery. Guess which one had subsidence? The one with the screw at the periphery. So probably screw positioning in the facet has a role. And again, another case with dorsal positioning, it's very difficult to hit the center of the facet. But this dog had infection on the C71 disc space. Well, just one last paper, almost done. Very difficult paper to discuss because of 9 patients, 5 with single space, 4 with double space, several different implants it used, but all bicortical implants were placed with the assistance of a specific 3D printed drill. And minor complication, 1 breakage, 1 fracture, 2 vertebral arches, 4 back outers, no major complication. But subsidence 33%, 1 out of 6 clinically significant, but it was a double space, so it's not comparing to violation, 2 minor violation, 2 out of 5 patients, or 2 out of 24 schools, depending on how you want to evaluate it. I don't think it's really a benign violation, this one, but of course depends on several factors. So I think I raised the doubt that indeed surgical treatment are not equivalent in terms of success, and the distraction fusion technique in general share a common ground of no progression of clinical sign, no steroids in post-op, no euthanasia. So I think if you are treating with distraction fusion, you are on, I think, in a safe side of the surgery. Complications are a problem because the negative or positive evolution is a toss of the dice, and ASP is a problem because can become symptomatic, and subsidence is a problem because early recurrence is a potential consequence leading to reinteroperation. Implant failure is a problem, like in every implant surgery, because early recurrence of clinical signs. And reintervention is a problem because it may indicate limits of the technique. So try to select the surgical technique as if you were the patient and not the surgeon. That's my take-home message. Thank you.